If you would, go ahead and place your name and campus in the chat. Be sure to check your screen name and ensure that it appears how it appears on the roster. So check your first and your last name on the screen. If you need to change it, you can click the little dots and the menu will pop out for rename, but ensure that your first and last name matches as it appears on the roster. As always, these sessions are recorded and they are viewed by the attendance administrators. So make sure you're placing your campus in addition to your name in the chat. If you only place your name, go back and put your campus. So good evening again and welcome to week 2. Hopefully everybody's doing well. So be sure to place your name and your campus in the chat. If you only place your first and last name, go back and put your campus as well. Check your screen name and make sure that you change it if it does not match how it appears on the roster. All right, so I know it's the same time, but once you get to that exam one for your classes, it seems like that time speeds up. So again, we do encourage you to look at your calendars. Some things you may have to rearrange, put on pause. Some things you might have to delete, but just make sure that you're looking at your calendars and revising them as needed. If you're taking, several classes, some of those exams might fall on the same day. So just make sure you're, thinking it through about, how your schedule should look and what you need to adjust so that you can do your best on all of the exams and with the coursework. Since you all are right here at the end. And also, I know you have free time. So with that free time, go ahead and do some extra looking in your NCLEX books, doing those pack practice questions. But remember, your next step is taking that NCLEX. So I know they have things, penciled in at the end, but you can go ahead and start just doing that on your own, just doing that complete review of everything.
Excuse
It's,
me, Miss Four.
mm-hmm.
Am I still in your class?
I'm not sure. Check your actually check your schedule and see.
Well, I was in your class last week.
Okay. Yeah, just check your schedule and see if you're supposed to be here on Wednesday nights at 5:30.
Yeah, that's what my schedule says.
Okay.
But I had somebody else inboxing me, but about a group, putting us in groups, but they never sent like a link for Zoom.
Not sure. That wasn't me. I haven't sent out groups yet. We're going to actually talk about that today. So our schedule will be today. We'll look at week 1. Check your schedule though, Miss Dance too. We will look at week 1 because that, like I said, the exam is next week. Just check your schedule to make sure that you in the correct class.
Yeah, on my schedule, I'm in your class.
Which class are this is leadership. Is
Yes, I was in
leadership.
here last week.
I understand that's what you're saying, but you're not on the roster, I don't believe. So you want to make sure that you're in the correct class. Me just stop for a moment and look. Classes were combined and canceled. And so let me just check and see. If you're receiving communications from someone besides me, that means you probably are in who's ever you receiving that communication from.
Well, when they was gonna tell me?
Yeah, because now I think about it, I don't think I'm in your class either.
Okay. So you would need to check your campus view probably if your printout schedule is different. I'm not sure where you would need to look. Who was the other person that said that? I didn't see the screen.
Tanaja Pugh. I got an email. I think I got the same thing she talking about.
No, Miss Pugh, you're on the schedule.
Oh, thank you. Let me mute.
Miss Bamster, nope, I don't see you there. So look at your campus view and make sure that you're in the correct place, you all. I
Can
think
you
is that
check for
any other place that you all can look to verify? I don't know where else you would look. I'm not sure.
can you check for Pamela Radden?
Yes, let's see, Miss Braddon. Yep, you're in this class.
Okay, thank you.
Hmm.
Okay, I see something from a teacher, but she don't have any other information.
Okay, so we're gonna just pop. We'll talk about that during the break. But like I just said, you're not on this schedule.
So you want me to
So
exit out?
you would need to and find out whose class you're supposed to be in. There, I think 3 classes that's running right now. Dr. Tenza, is it Martinez? And who's the other? I'm not sure who the other person is, but and if who did you receive the communication from? Start there. It didn't come from me.
Some Martinez or something.
There are 3 classes at 5:30.
Okay.
All right. So again, place your name and campus in the chat. In addition to that, check your screen name to make sure that it shows how it appears on the roster. So we will do our groups at the end. The groups, the week 10 group. So we'll do small groups today too to review some information. But at the end of class, toward the end of class, we'll let you get in your group 10, your week 10. I keep saying group 10, week 10 group so that you all can start that communication. Then the second half of class, we'll actually look at week 2's information. And then right now, we're going to review week 1. So as you move forward, even though we're past exam 1, you want to still be looking back at week 1, 2, and 3, just so that you can review and continue to strengthen that foundation of those concepts. Because remember, these questions, some of them will ask you like to define something, but most of them you have to really apply what you know about that concept and pick it out of a scenario. So that's why it's going to be really important to just, don't, after we finish exam 1, don't drop that information. Start back looking at week 1, too, because when you get to the HESI, it's going to be anything that we've done the entire term. So if you continue to review, then you'll strengthen your foundation. So let's go ahead. Anyone else here that figures that need to ask if they're in the wrong class? But for sure, if you're not seeing this class on your roster, and I haven't sent a communication to you all, you're in the wrong class. There are 3 classes that are running right now. So make sure, check that, because remember the classes, they don't swap out you all. You have to be in the correct class. All right. So question to you all. What guides us? Like we said, the questions are going to be next gen. And delegation and priority, we have heard that is pretty much a huge bulk of what the questions are about, even though they are about different concepts. For example, in the scenario, you might have a patient that has hypertension, might have a patient that has asthma, but also that patient may also have stepped on a nail and they're bleeding. And so with all the different situations and you having to select all that apply, priority, determining who, let me make sure we're recording you all, determining who needs further teaching and so forth. What helps the nurse to determine what's priority? You have all of these patients, and mind you, we're going to take care of every one of them. But what helps us to determine, what guides us?
ABCs.
And what's acute and what's chronic?
Okay. All right. And then but after ABCs, if our patients don't have anything going on with their airway, breathing, and circulation, what's that next guide? You all said acute, chronic.
Acute or chronic, or like the age group, maybe. I don't know. I wouldn't say age group. Acute or chronic, ABCs.
Next question again, please.
Yeah.
What guides the nurse in determining what is priority? We're trying to determine. We have all of these patients we need to take care of.
Maybe like the age group, because doesn't don't babies go down? Babies and older people go down faster.
The worst
What
patient in a situation.
How about the lab words?
Okay, so I need you to put it on pause, you all. Think it through. Go back through your files. Priority. We're trying to determine whether or not it's life-threatening. So that's ABC, airway, breathing, and circulation. That part is fine. What else determines what's priority?
Like maybe their level of, I don't know.
That's airway, breathing, and circulation.
Yeah.
So remember,
I feel like you're going
let me put you on pause again. Remember, I just said, in order for you to answer the questions, you're going to have to be able to apply what you know about that concept. So if we're saying airway, breathing, and circulation, please recall an example of what that might be. So if a person is completing sentences and they're engaged in a conversation with you, that's one patient. We have another patient that is out there. They were doing jumping jacks, and all of a sudden they could not continue the exercise. They bent over, couldn't continue the exercise. They stopped. And they actually leaned forward. The other person was, you were talking to them, but they were responding, but they could not complete sentences for having to, to catch their breath or something like that. Which of those patients is priority?
The one that's swooping on you.
The one
I
that
would say
Take
that
complete
the
sentences.
complete
I
sentence.
say the third
Sentences.
one.
Okay.
Based on the assessment, yeah.
Yeah.
So what helps us to determine priority? Airway, breathing, and circulation. Which one of
Level.
those patients is having a problem with airway, breathing, and
Airway
circulation?
breathing. The one that's shortness of breath, right?
Which
Right.
which is doing what? Which one of those patients? The one that cannot
That's
do
what,
what? Complete the sentences.
Yeah, the
So
third.
Yeah.
I need
Yeah.
you to listen up. I need you to understand what airway, breathing, and circulation is. Seems like you know that part, but I need you to be able to apply it and pick it out of a situation. If a person cannot complete sentences, they're having to stop and gas, stop and get, you know, rather than just completely talking, they're having a problem with gas exchange. The person that was doing the jumping jacks or the exercise, something, that person just got tired. We didn't say
Right.
that they were using accessory muscles. We didn't see any
Right.
nasal flaring. The other person, what were they doing? Oh, they were just talking. They were just rattling off. So be able to, when you say airway, breathing, and circle, be able to apply it to the situation. A lot of questions are priority. The question was, what helps you to determine priority? You all said airway, breathing, and circulation. Then what's that next thing? Maslow's hierarchy of needs. What's on that bottom layer? A person, they're fine. Their airway, breathing, and circulation is fine. If they don't have anywhere to stay, they don't have food, shelter, if they're in pain, that's going to be the next that help you determine priority. So we know that, but think of the situation, just create a scenario in your mind that you can apply that to. Okay, so the next question is clinical judgment. So let's talk, we had Tanner's model. So specifically, let's talk about interpreting. What does that mean when we're interpreting? And when we are interpreting, I'm trying not to say the answer here. When we're interpreting, give me an example of that. When the nurse is interpreting, when we're talking about a patient, when we're doing what? What's some examples of that?
Like the assessment or like,
Explaining the patient.
yeah.
Explaining.
Okay. So
Or
it's
get the
using that
feedback.
data.
Yeah.
So we're using that data that we have gathered or assembled that we have gained from that client. Even if we were doing a head-to-toe assessment, if we were doing an interview, we're getting all of that information. And then we are putting it together, making sense out of it, see if there are any connections, identify if we need to go back and ask some more focused question because it might be some issues, some information that might be a little lacking. And so we would need all that information in order to move forward for that RN and you all to collaborate to make that, to complete the care plan. So interpreting, you don't really think about it like that. You say, well, I'm just doing my head-to-toe assessment. I'm just gathering information. But you really are, as you're interacting with that patient, you're hearing what they're saying. You're looking at them. You're looking at the vital signs. You are feeling the skin is warm to dry. All those different things, all that data that we're gathering. Even if we're looking in the chart, we're getting objective data from the labs. Their red blood cell count is this, their white blood cell count is this. Even then, that's still gathering that data. And as we're looking at it, remember, you all have learned what for the most part, what the values are. And even if you haven't, you can still look on that lab slip and see, oh, well, this is high. And even at that, most lab slips print out like an H or L, or they'll have it'll be bolded. So when you're looking at that data, you are interpreting that data. You're looking to see what's relevant. And then you will be looking to see if there are any connections. Well, this person told me that they were anemic. So when you're looking at the lab values, their H&H, their red blood cell count is low. So more than likely, when you look at the medication list, okay, they are on replacement iron. They're having to get iron infusions. All of those things start to come together. But nevertheless, Remember, we are interpreting data. ABCs guides our determination of if it's priority. So don't think we're not going to take care, because when you have those questions, you all, situations, don't think we're not going to take care of the other clients. The question is asking you which one we should take care of first, priority. And then after ABCs, Maslow's hierarchy of needs, and we start at that bottom of the triangle. If those things are met, and remember, people, we can all go up and down that triangle. Let a storm come through, a flood come through. It can leave us without shelter, food, electricity, all of those things in a drop of a moment. So a person can go up and down that triangle. But nevertheless, we want to make sure those basic needs are met first, because all the other stuff on the triangle, it doesn't matter at that moment in time. If I'm trying to find somewhere to live or trying to have food or something to eat. And remember, are our care plans patient specific or are they general? Are care plans patient specific or general?
Patient
Patient.
specific.
What's another word or phrase that we use for patient specific when we're talking about taking care of our patients?
Patient-based care.
Okay. What's another phrase or term?
For patients,
What's another word we can say?
individual care plan.
Individual. What's another word we can use? Unique, individual. So, and I got you to say those different phrases, because when you see those different terms, don't get confused. They all still mean the same thing. It's specific to that person. We have 3 patients. 3 of them have diabetes. One has a broken hip. One is in because they're having their toenail removed. The other one's in because the blood pressure was up. Even though each of those have diabetes, their care plans will be patient specific, unique, individualized, because each one of those persons are different and their situation is different. Test taking tip, don't get confused when it says patient specific, individual, or unique. All of those is the same thing. All right. Any questions about the information that we went over so far? All right. Nursing process. What's that first step in the nursing process?
Assessment.
Assessment.
Gathering data.
Assessing, gathering data. What's some other words we can use that mean the same thing as assessment?
Gathering data.
Gathering data.
Evaluating.
No, it's not evaluating. The first step is the first step in the nursing process is what? Assessment. We're not evaluating just yet. Gathering data.
Observe.
We observing. Okay. All right. So remember that step, that first step, during that phase, we are getting all of the information from the subject. Got no subjective, and then we are using 4 by 5 senses. What are we touching? What do we hear when we listen to the heart sounds and the lung sounds? What do we see on that blood pressure dial when we hear the boom boom? And they have like a wound or something, does the wound have an odor or does it not? We're using those 4 of those 5 senses. If we're looking through the chart, that's objective data. So we're still assessing. We are collecting information so that we can decide what's the plan. Let's do the plan. That's interventions, implementation, and then we're going to evaluate and see if our plan works. So again, the tests are going to be really like the NCLEX tests and the unit exams is going to be applying what you know to the situation so that you can pull out and identify the correct answer choice or response by the nurse. But don't think we're not going to take care of everybody. And you all mentioned acute and chronic. So if they give you a situation and it says this person, has a long-term history of, that's chronic. So then think about, is this another thing to think about too, I thought you were going to say it was expected and unexpected. So we're looking at this situation at the scenario, and it tells us that the client, has a history of hypertension, and we check the blood pressure and it's probably 150 over 88. Well, this person does have hypertension. Are they taking their medicines? Did they take their medicines today? Are they not on any medicines? But they already have a diagnosis of hypertension. So We want it to be close to normal, but sometimes if they're non-compliant and they already have a diagnosis of hypertension, is this expected? More than likely, it probably is. And then we will ask those more focused questions to see, well, hey, are you taking your medicine? If you are, when was the last time you took it? Are you taking it as prescribed? And we will go in that more focused, more focused question assessment. But nevertheless, we're still gathering that data. Okay, so we're going to switch it up here. We have, I think, 5 slides. No, I think it's 6 slides. Going to send them to your mail, your Canvas mail. And just push them out real quick. We'll give you about 5 minutes just to just do some jot noting. You don't have to do any extensive noting. Just listen to each other, discuss each slide, and you all come up with what you think that's going to be the best answer for that question. And we'll come back and we'll review those slides. So let me open up the breakout room. So what are you getting ready to do? You're going to go to the breakout room and you're going to go to your Canvas mail. There are 6 or 7 slides there. Discuss them and just do a little jot noting. And we're going to bring you back and we're going to share out. Shouldn't take any more than about 5 minutes. Okay. Accept the invitation to the breakout room and look at those slides. I'm going to put my timer on for 5 minutes and we'll bring you back and we're going to share out. It's in your Canvas mail, not Outlook, in Canvas. Get my little timer pulled up. My little timer here. Ms. Trapp, are you having connectivity issues? It looks like you're frozen. Yep, I think so. "15 seconds, everyone should be back." Okay, I think we have everyone back. Let's start with that first slide. We'll just go with the group. If I can see my thing here. All right, let's start with Pew and Bell. Which of the following will dictate your role as a licensed nurse? What did you all come up with?
We have put A,
NPA.
Which stands for what?
nurse, practice,
Practice Act.
practice,
Yes.
nurse practice act.
Yes. So each state has their own Nurse Practice Act. It is our lawfully to-do list. These are the things that we can do lawfully in that state as a nurse. So in the event that you are licensed in 10 states, 12 states, whatever, make sure that you are following the guidelines for your Nurse Practice Act for that state. They're not that big of a difference in the Nurse Practice Act from state to state, but there are differences. So, and then unfortunately, sometimes people will ask you to do things that are not in your scope of practice, that are not on your lawful to-do list, which comes with that Nurse Practice Act. So it's going to be on you, because these are going to be your license here in a few months, to know what's in that Nurse Practice Act and to say yes or no that you can't do those things. You will, once you pass your boards, and even I think if you apply for your temporary, some states go ahead and start sending you that Nurse Practice Act information specifically to you. They have these webinars on it so you can gain understanding of it. But it is our lawful to-do list. Those are the things that we can do lawfully within that state. Now, from that Nurse Practice Act, there are the facilities, what they'll do is they derive their policies and procedures from that. So, but sometimes there are policies and procedures need to be revised. So it's still going to fall back on the nurse if they do something that is not on that's within their Nurse Practice Act and it get called up on. If there's a complaint or, if a patient decides to report the nurse to the board or something happens and the information about the whatever happened has to go to the board, they're going to look back and see what the Nurse Practice Act says, what was that policies and procedures of that facility. And then they use that. That's the gauge that says, hey, this nurse did what they were supposed to do, or this nurse did not do what they were supposed to do. So that's our to-do list. Those are the things that we can do lawfully. Now, another thing, hopefully you all have been looking at your different settings that you've been rotating through and determining, which settings that, best appeal to you, because even though we can lawfully do all of these tasks, personally, you might not want to work in that setting. So start thinking back and thinking about the settings that that you might, do your top four for. What are your top four settings? And then, because there's so many different areas out there that you can work as a nurse, but just narrow it down to your top four. And once you go in for that interview, you want to look at that task list for that setting, for that facility, and make sure those are all things that you are willing to do, within that facility. All right, so the second slide, which of the following is the primary source of data collection for a client? Let's see, is it Durant, Clark, and Trapp? You all were in the same group. What did you all come up with?
The patient.
Okay. The client, they know their body and themselves better than anyone else. So unless they're extenuating circumstances, that client can't respond. So you can't go wrong with the client saying. And then I think it came up too, well, what if the client tells you information that's incorrect? Sometimes you do get that information that's incorrect. They may have Alzheimer's, and sometimes people just don't tell things that are true. You still want to capture that. That would be a care plan for that client, because in the event that something happens later on and we have it captured that this client stated this thing, but once it was verified, we found out that it wasn't truthful information. You do want to have a clear picture of that patient. You don't want to dismiss. Well, you're like, well, I know that patient's not telling the truth. We still want to give credit that they stated whatever it is that they stated. So as you're documenting, make sure that you're putting those quotation marks or saying that the client stated whatever it was that they stated. But yes, that client they know their bodies, they know themselves, they know. So like I said, unless they are incapacitated and can't respond. Good. Okay. All right. Let's see. Presley and Murphy. Nurses frequently use Maslow's hierarchy of needs to prioritize that word again, client's needs. Which of the following are the client's highest level of needs? According to this question, I think we need to reword it, because according to the triangle, which one is the top layer on the triangle? Answer that question first.
A.
On the
Top level
The
is
top
C.
layer is actualization.
I don't
self-actualization.
know. Let me see. Hold on. Wait a
Okay,
minute.
now let me reword the question.
Let me go back
Which
to the
one is priority according to when you're looking at all 5 levels? Which one is
A.
priority?
A.
I got to go back
The
to this
bottom
A.
layer. Exactly. Yeah. And I said the question, we needed to kind of rephrase that one. But if we're looking at the 5 layers, and between those, if we're going with airway, breathing, circulation, the next thing will be food, water, and rest. So that's correct. But if we were picking out looking at the triangle, the top one is self-actualization. So yeah, that question needs to be reworded. Okay. All right, so we know Florence Nightingale implemented medical asepsis, and who would have thought? Just washing your hands, cleaning off surfaces, and just sanitation, having clean linens. making sure those linens are nice and taut and wrinkle free, having those nutritious meals. Not maybe it might not be what you really want, but it's a well-rounded, nice, nutritious meal. Those things would help someone heal. So hopefully you all got that one selected, that one for the question about Florence Nightingale. So she implemented medical asepsis by improving sanitation. You know, that count. How long do we need to have that friction? Making sure that we're wiping down those surfaces, doorknobs and countertops and everything. All right. So what change occurred in the role of the practical nurse in hospitals after World War II? Let's see. Ashbury and Glover, what did you all come up with?
Um, Increased responsibilities due to nursing shortage.
It's been a nursing shortage forever. I've never known them not to say it was a nursing shortage. It's like, what is it? And they've made changes across time. But for example, the different types, the boards of nursing, each state has their own board of nurses. So they determine the seat time. So that's why some classes are longer than the others. That's why some classes you might have clinicals, some classes you may have clinicals, and you have to have this number of hours. Those boards of nurses, they gauge all of that. They changed it up. Like even during COVID, they allowed, because initially you had to have so much interaction in person during clinical, but during COVID, they did adjust um, those parameters. And so that's how simulation was a thing, but it became a huge thing because you could also use some of your clinical hours for simulation hours or vice versa. But before then, they just counted as simulation hours. They didn't count as your real live contact hours. And I think I just don't know what we can do differently to decrease that shortage. But it's been an issue for a while, that nursing shortage is as far back as World War II. People retire, people go into the profession and they change to something else because there are nurses that are all different things besides being a nurse. So there's so many things that contribute to it, but that nursing shortage is a real thing. Okay, so let's see. Did you all have the slide about COVID? Let's see. Let's see who can help us out. Michaela and Brianna, what did you all come up with? How did COVID-19 impact the demand for nurses in the nursing workforce? What you all say?
We said B.
Okay, and let's see. I share my screen here. So you all said B. Slideshow from the current slide. The COVID-19 pandemic led to increased demand. So there was already this shortage, you all, and then now there's an increased demand. But public health in community settings, because the way COVID-19 affected people, if you could stay at home and everything that was going on, if you could stay at home, then that's where people wanted to be. So that led to the increase of community settings. You could drive up and get the shot. You could drive up and see the doctor. They have like this telehealth went just boom because it allowed that person to stay at home, or they could. I always had the option to actually go to the hospital, but it allowed that person to be in their home and receive that care in their home settings. And so there was already a shortage that led to even increased demand. And so what do we do now? What things are these nursing boards are going to do to address it? Because it's only so many hours that you as a nurse can work, and so many hours and so many hours. So it's like, what do we do? Okay. What is the role of an LPN in the nursing process compared to the RNs? Let's see, who do we have? Let's see. I think I called on you all already. Volunteer, someone.
Would it be
B.
B?
B, yeah.
They collaborate with the RN all steps except the nursing diagnosis, which is the RN's responsibility. Okay, so we are independent. We can go in as LPNs. We go in. We can do that assessment. We can gather that data. The RN doesn't need to be there with us. Also, we can implement. We can administer those medications, do that dressing change, but with the nursing diagnosis, and also you all know that nursing diagnoses are different from medical diagnosis. Nursing diagnosis comes from the NANDA list. And so Just stop sharing right here. And then I don't think I told you all, there's a reminder, these sessions are recorded and they are viewed by the attendance administrators. I just like to remind everybody of that. So just make sure that the setting that you're in is appropriate and all those things that we mentioned in week 1 about, what's expected in this setting. So just make sure we're adhering to that. All right. So let's go here. All right. If a client's subjective comments do not match objective data, what is the appropriate action for the LPN? Okay.
B.
We're going to report. We're reporting
B.
what those findings are. We got to report all of it. Just report all of it. We want to capture it all. Okay. And so we already talked about the Nurse Practice Act, determining our legal, lawful scope of practice. These are the things that we can legally or lawfully, we can actually do those things. Okay. So when the actual care plan is being devised, we want to make sure that things are measurable, realistic, and time reference. So I know you all may have those care plan books, and if you look at them for the intervention parts, when you all look at those interventions, they have them divided up for they're age specific, and they also, most of them are setting specific. I forget the name of the authors, the book that we use, but make sure that the intervention is something that we can actually do in that setting. They're all kind of interventions for someone that has, what's ANANDA? I think ANANDA is unstable blood pressure or decreased cardiac output. There are numerous interventions, but is it realistic for this patient? Is it measurable? We're going to administer antipyretic every 4 hours. We're going to check the temperature every 4 hours. Can we really do that? Should we be doing it every 4 hours, or should we be doing it more frequently? So making sure that that it's measurable, realistic, and time reference. Okay. So rapid changes in information explosion as things have advanced. New medications, they've learned and changed things up about, how to take care of a person that has hypertension. They have increased people's skill set, how to manage their own wound at home. All of these things have led to just a better quality of life for everyone. So this question says, why is it important for LPNs to improve their critical thinking skills in today's healthcare environment? Rapid changes in information explosion require nurses to develop new learning and workplace skills. So even for those you in your workplace, I think they're often sometimes, and you all may have encountered this in clinicals too, where they are you see signs saying training, today at 2 for whatever, training to tomorrow or next month. It's just an ongoing thing because things change, and they should for the better. So as those things change, the facilities policies and procedures should also match, but it should also match our scope of practice that comes from that State Nurse Practice Act. So critical thinking, I have made some little notes on critical thinking in nursing is guided by professional standards and evidence-based practice. Let me look at my little notes right here. So critical thinking, we're all the time assessing, need to know assessing. We're talking to that client we're assessing, we're gathering their vital signs. We are feeling their skin. We're asking those questions. We're measuring that wound. We're all the time assessing. We want to verify that information that we're getting too. Like, for example, if we get a blood pressure that's like really, really way out of range either way, we want to make sure that information is correct, because our next steps would be calling that doctor and reporting. But we got to assess and gather information first in order to be able to report. But between assessing and calling that doctor, we're analyzing. We're like, okay, well, I got this blood pressure. This blood pressure is normal. This blood pressure is high. This glucose is high. This glucose is normal. So we're analyzing it, and we're identifying if there's a trend. So when you call to report, okay, well, when the blood pressure was checked, when I got report, the off-going nurse told me that the blood pressure at 3 o'clock, it was whatever it was, and then I've just checked it, and it's this. And a lot of times they'll ask me, well, what were the last three readings? Sometimes they'll ask what was the last three, or when was the last time this client took their medication? So they're still complaining of pain. What's been the trend? Does the patient complain of pain every day at this time of day? So we're assessing and analyzing, are there any trends? If we are in the home setting, is there a language barrier? Do this client really understand what we are? Even if there's not a language barrier, do they understand the information that we're giving them? And so, because remember, we want to talk in those layman terms, because more than likely they're not healthcare professionals. And even if they are, if we're taking care of them in their homes and at bedside, we want to put things so that they can understand, because we want them to walk away with them being able to manage, decrease rehospitalizations. We want to decrease amputations and all of those things. And for the most part, it's not that people don't want to take care of themselves. They just don't really understand how, and they don't have the necessary tools and equipment and the resources to do that. So critical thinking involves that purposeful, evidence-based decision making. We are assessing, we're gathering data, we're verifying that that data is correct, and then we'll notify that physician. When we're verifying that that is correct, we're analyzing and say, well, hey, this is normal. Okay, I'll check, it's not due again until 4 hours, or this is abnormal. Let me go ahead and notify that physician. All right, let's see here what we got. What is the relationship between self-confidence and critical thinking for nursing? Let's see, self-confidence is developed through successful experiences and enhances critical thinking. So be thinking about, your clinical rotations, even your simulation labs, because we want to build upon those things. Go back to your theory. What was in your required readings? What did it say that the response should have been, or what are the interventions for a client that has, that similar situation? When applying clinical judgment, how does a nurse typically use knowledge and experience? It says a nurse uses both theoretical knowledge and previous experience to notice relevant cues and interpret the patient needs. Because remember, when you're going out taking care of your patients, it's like you're having to apply what you know about a situation. It's rare that a person just has one thing wrong with them. Like I said, those 3 patients that come in all have diabetes, but then one is there because they're having hip surgery. So think about what you learned in med surg, what you learned in A&P, what body system mostly has to do with mobility. What are those organs? And then bring them across. What did we learn about osteoarthritis? What did we learn about rheumatoid arthritis and all these different disease processes? Then, okay, what lab bags? What x-rays would they do? Are there any x-rays? Are there any lab values that would indicate or verify this client has this medical diagnosis? And then what do we do to take care of this client? What do we do to teach this client to take care of themselves and manage themselves? So it's like a domino effect. You need that base information from A&P, med-surg, all of your different courses up into to now is bringing it all together. So pattern recognition, let me check my time. Got a few more minutes before we stop and take our first break. Pattern recognition allows nurses to quickly identify clusters of symptoms and respond appropriately based on the experience. So you should put, you're going to start pulling out your files like, wait a minute, okay, I'm seeing this, went in, the client, like those 3 patients I gave you, one was talking, no problem talking. The other one was doing these exercises, they just stopped, bent over. And then the other one was having problems completing sentences. They were having to stop, gasp for breath. And so as you're seeing this, and as you continue to put together all the information that you know, because it's rare that you all don't know the information, it's just putting it together and making the connections. But once you continue to do that, you'll be able to quickly identify, this client, I got the low O2 sat, they're using accessory muscles. You're going to okay, we need to, get this client, change their position, see what diagnosis they have. Do they have any respiratory issues? And those are just some examples, but you start quickly identifying symptoms and then responding appropriately based on that. Because in a few months, you're going to have that team, those 4 and 5 patients. In addition to that, depends on what setting you're in. If you're in those long-term care facilities, it might be 15 patients. So not saying it to make you afraid, but you do have the information. It's just being able to prioritize, think it through. Even if you have to go think back, and I'm literally, what body system is this? What organs? And then and then think about priority. We've already said ABCs. Then we said Maslow's hierarchy of needs, starting at that bottom, which is the highest level if we're talking about priority. So let that be your guide. And don't be fooled in thinking that we're not going to take care of the other client. But fever, respirations, and things like that. Someone has increased respirations. We're going to take care of those patients first. Can't get away from that priority. And I'm just going over it and just hammering it because it's going to be there. Assessing, interpreting, critical thinking. All right, let's move forward here. Got a few more minutes before we stop and take our second little break here. Let's see me look back at my notes for critical thinking. Excuse me. I think that's it. All right, so let's pull over to week 2's information. Share my screen. And I didn't say either of this, you have to walk away from the camera for any reason. If we're not on break, just put a message in the chat to me. You don't have to send it out to everybody. Just make sure you put it in the chat. Okay, so we asked about the World War II question. Let me go back and look at it. Hold on one moment.
Miss Martin, is the slides that we just went over, is that gonna be on the test too, for something we need to study for?
I need you to go back through our classroom recordings and listen to what we discussed. I want you to get focused on the slides, which is still the same thing. I want to say yes and no. It's yes and no, but it's more of understanding why the answer is the answer.
Okay.
So is it going to be those exact questions? More than likely not. But if you understand why those answers are the right answers, then you'll do well.
Okay.
Just like how we talked it through about the ABCs and picking what's priority, you do have a good understanding of how to pick that patient out, then you're going to do well, because no matter how they have those patients lined up, you're going to pick the correct one out of it. Assessing, analyzing, identifying the patient's preferred learning style, providing that teaching. Those are the huge concepts. You're going to have to know that information to apply it. So are those exact questions going to be on there? No, but understanding that information is. So make sure you go back through our classroom recording, not specifically the slides. Someone asked about the one about the World War II. After World War II, practical nurses gained increased responsibilities in hospitals due to nursing shortage. So, I don't know if you've worked on floors or a nurse that has. For example, some floors you work on, you do everything for the client. Some floors you work on, you might have unlicensed personnel, you may have a PCT, and they have various names. Glucoses may be obtained by them. They might perform the bath. They might measure the blood pressure. But on other floors, that nurse does everything, bath, the medications, and all of that. So after World War II, practical nurses gained increased responsibilities, especially in hospitals due to the nursing shortage. Because yes, can we give a bath? We can. But if you have, in some settings, if you have other staff there and that setting budgeting allows these other people to work, then they allow the unlicensed personnel, the PCTs, and all of those to come in. Just checking the chat to make sure I've answered all those questions. So what do we do during the assessment phase?
collecting data,
We're collecting data.
gathering information. Yep.
Mm-hmm. Assessment phase, we're collecting that information. We're collecting yes and no. We are collecting that information. Let's see. I wanted to ask you all about, I know what it was. Let me give you some examples. What was my examples? If we are, does this require critical thinking? Yes or no? Does this situation require critical thinking? Let me give you some situations. We've got the patient's blood pressure measurements, and we're analyzing them. We're looking at the blood pressure measurements. We're looking, okay, does it have, and this should be the nurse's thought process. Okay, is there a trend? Is this blood pressure staying the same? Is it going back to normal? Is it increasing? So that's that analyzation. Is that critical thinking?
Yes. Knowing the
Yes.
blood pressure.
No, it's not really critical thinking. It's just kind of like analyzing the data. So I guess it does sound like critical thinking, though.
Which is it? Yes sir.
Say that again and say it again.
Critical thinking.
Oh, you gonna make me make that up again. Let me see.
I say yes.
Let me see. Okay, so we have a patient in 201. We're looking at all of their blood pressure measurements. We're looking at their glucose measurements. We're just saying, we're looking at some of their data, and we're looking to say, are these normal? How are they trending? They trending up. They're trending down, or all theirs they're about the same. This is just information that we're looking at. Is that considered critical thinking?
No, because it's objective data. This is stuff that you see. Critical thinking is more so you have a situation and you have to think beyond, like outside the box. I think about it like that. Like, okay, this is my situation and what I'm gonna do about it.
Is that not the scenario that I just gave?
Yeah, I think
Would
it
it
was
be
still
yes
critical
because you're trying to
thinking.
figure out what's
Yeah, but
It was still,
But I'm observed. I could see that. I could see that it's
You're looking at that information. You're looking at these glucoses. You're looking at these blood pressures. You're analyzing it
yeah.
and
That's
saying, wait a
board.
minute.
why is
Critical
it how
thinking.
what's going on with, right?
Wait a
Yeah,
minute.
you
Say
was
that
kind
again.
I think it's critical thinking.
yeah, well, it's critical thinking.
yeah, I will. Yeah,
It is
Yeah, I
because
mean,
you
You
got to think like,
we
what's your
really are critical
baseline?
things because
Yeah.
we've gotten so used to just looking at numbers and things. It's second nature to you, but you really are critically thinking. You really are, because
okay.
you're like, okay, wait a minute, what this patient doing? Is it normal? Okay, they okay. Oh, this person's trending up. Their fever is going up. This fever is not getting any better. You look back at the medication list. When was it last given? Can you give it now? What other? It is critical thinking.
Okay.
It is critical thinking. What about if we are reinforcing teaching and the client says, hey, that RN came in here and I didn't know what they was talking about. And the LPN says, okay, well, let me see. How do you learn best? Do I need to, I know we gave you these handouts, so I need to read through with these for you. Do we have some videos available? How do you learn best? Because we want to make sure that you understand this information, because you're getting ready to go home, or you're in the patient's house and you're getting ready to leave, because remember, home health, you're not there, but you're there intermittently. So you want this client to be able to understand. So was that scenario, is that critical thinking?
Yes.
Okay. All right.
I say yes, because you have to think, versus like if you're talking to somebody older that doesn't really understand like the new wave of everything, you have to understand the talk the way they will understand it better, because you just throwing words at somebody, they're not gonna understand something.
Exactly. Okay. So what do we do? We have a client that the unlicensed personnel say, hey, patient in room 201, they are slumped over on the bed. We go to that room. What do we do?
You're asking us.
Check the breathing.
Ask them to see if they're breathing first.
Yeah, try to get a response and then
We're trying to get a response. We're checking their breathing. We're measuring their vital signs, all of that. What if we have a client that may have fallen? Patient in room 201 hollering out for help, help, help. And we go in, we see them sitting on the floor. What do we do?
Assess them, see if
And check their surroundings, right?
check their level of
Check them,
assess.
assess,
All
assess,
those
assess.
things that you are saying equals assess, assess. Remember, I said assessment and interpreting and analyzing. Those are those keywords. And you all, you know the answers, but you need to know that it falls under those categories. We are assessing, we're analyzing. Good, good. Okay, let's pause and let's take our first 5-minute break. So we'll see you back at 6:39. So this thing still plays you all, so make sure your camera's off and that you're muted. 6:30. All right. Excuse me. Let's come on back. Finish our content for week 2. And then we'll move on into, we'll take another break, and then we'll move on into just meeting and greeting each other for the group projects. Okay, let's see where we at. So what if we are administering, a patient is on a medication daily at 8 a.m. They're on a medication daily at 8 p.m. Is that considered as critical thinking?
No.
I would agree. Now, if we were administering that medication and we had to, like, for example, digoxin, we're having to check the pulse, and then we're having to look at, determine whether or not it's above or below, whether or not we would administer, then that would be critical thinking. But if we're just administering that same medication, same time, and we're not having to do anything, any assessing, interpreting anything, then that's just that doesn't really require critical. That's not what they consider as critical thinking, compared to like the person that's on some blood pressure medicines too, that they'll have like a parameter. They say check the blood pressure first. If the systolic is, whatever the number is, then you have to judge whether or not to administer it or hold it. And so that does require, I think I had a sneeze coming out, y'all. So what is it if we are, another word is noticing, that Tanner's model. It's me. That was a big sneeze. So another part of Tanner's model is noticing. It's noticing. So those patients that, they reported us, they told us that, person was slumped over, or the person was hollering out because they, hurt themselves. Noticing is another thing, a term, but it's also still assessing. Even those small little changes, patient in room 201, they just not acting themselves today. Noticing those small, which is still also assessing those small changes in behaviors, and identifying whether or not, because usually, especially if you're taking care of a person, even those 3 or 4 days, you can pick up on their patterns and their cues and different things about that patient. But for sure, if a person is like in long-term care, or if you're doing like that home health and you're going there for an extensive period of time, you should be able to identify their patterns. So you will be able to notice if there are changes in a patient's behavior, or if, for example, if they're withdrawn, or they're responding to you, but they may be, you looking at the nonverbal, it appears that they are, I want to use the word appears, but they have facial grimacing. They have, they're guarding, as though that they are in pain. So we're noticing those small or subtle changes. It is very, very important, whether or not we're talking about behavior, their what's the other word I'm trying to use? For example, if they seem like they're withdrawn versus pleasant and calm, or they're being aggressive, we do want to notice those changes. And that will lead us to ask a more focused question when we're assessing and gathering data. I notice you're not perky or happy, or singing that song like you usually sing, or I noticed you didn't eat all your food off your lunch tray. Usually lunch is your main meal. Was it that what we served today wasn't, it didn't taste well? You got to change appetite, stomach hurt. It leads you to all those, asking those other questions. So evidence-based protocols, guidelines, everything is evidence-based. Like, why do we go back in, why is Tylenol 500 milligrams and 325, all those other doses? Why? That was our little timer. Why? It's because, evidence shows that based on the experiments and things that they ran, this is the amount based on the way that it's made up. So evidence-based protocols, they guide our practice. We're just not haphazardly pulling things out of the air. The evidence has determined this is what we need to do for a client that has diabetes, that has dressing changes, that has asthma, to prevent a client, if we're trying to put that has problem with mobility. Evidence has shown at a minimum we can change their and reposition them, more than every 2 hours, but at a minimum to keep that skin from breaking down, depending on what disease process they have going on. At a minimum, we want to change in terms reposition that client at a minimum every 2 hours. So evidence has guides our practice, the things that we do. And then that clinical judgment, noticing those small changes, helps us to provide that best care for those clients, because that helps us to adjust that care plan and to be more specific to what that client needs. That's another word. We said unique, we said individualized, specific, to meet that client's specific needs, their unique needs. So that helps us to, that care plan is just not something we have in writing. It really is the recipe, the roadmap to take care of me, that client that's in room 201. Is specific to them. And so noticing those small changes, assessing and gathering that data, it will allow us to identify the patient specific needs and adjust that care plan. And it goes back to week one's information when we said making sure that those interventions are realistic. So making sure that the things, the care plans, the things that we're going to do, that we're going to implement are realistic for that patient. All right, let's get back to our slides here. I think any questions about interpreting, critical thinking? Gave you some examples and you all answered correctly about those different examples. And so again, knowing and understanding the information and being to apply it to the situation. There are some questions it's going to ask you, well, what happens during the nursing process or things like that. But for the most part, you're going to have to be able to apply what happens during the nursing process in order for you to answer. All right, let's see here. Week 2. All right, so we're moving on into ethics. That's another sign too. If a person continues to cough you out too, that's something going on with that gas exchange. Not that I'm saying that's what I'm not having a problem with gas exchange, but those are some signs. Usually we think about using those accessory muscles, that flaring, not being able to complete sentences, but they have that continuous cough. It's something going on either in that airway, either if it's the body trying to get rid of that irritant that's there or something. Okay, let's see. You move this out of the way. All right. We're talking about ethics. Ethics. What is this ethics thing? It's a study or examination of morality through various approaches, you all. And then we're going to look at these different ethical principles. So, ethics is, is that right or wrong? It's our moral gauge. Is this the right thing to do or is this the wrong thing to do? So to be more specific, non-malfeasance, it requires the nurse to avoid causing harm to patients. We'll give you some more specific examples later on, but just know that non-malfeasance requires the nurse to avoid causing harm to the patient. So if you have a order, the dose of that medication is higher than normal or lower than normal. Okay, we have all the components there. We can go ahead and administer that medicine, but critically thinking, we think back, well, hey, wait a minute, I haven't usually seen this dose for this medicine. So we pull out our little drug book or we click on for the most part, you have those electronic health records, you can click the drug and all the information will pop up. And you can see what the normal doses are. And then you look back and see what have this client been taking, because people are on high doses of certain medications. But if it's their initial time taking that medicine, they usually start them off on those initial doses. So that's just an example. So do we go on and just administer because we have that order, or do we make that phone call to that physician and say, hey, just checking, making sure, I see that the patient in room 201, they just started this medication, and then the order is for, is this just confirming? Because at the end of the day, we're the ones that's going to give that medication. Even though the doctor put the order in, pharmacy actually filled it, put it in the bottle, the container, however they do it, but we actually gave it. So we do want to make sure that, because we don't want to cause the patient any harm, so we question that order, clarify, verify. So the Code of Ethics for Nurses establishes clear priorities such as compassion, respect, advocacy for those patient rights. So applied ethics refers to the process of approaching daily life situations with ethical theory and reasonings to daily life situations. Again, we want to provide that specific, unique, individualized care for those clients. So another principle, we just talked about non-malfeasance, is justice, treating all patients equal and fair. Patient always comes in on the 10th of the month. Their blood sugars are always high. Well, that client might have ran out of medicine. It might not be that they don't want to take care of themselves. It might not be that their budget allows for more medicine. So rather than just stay at home and wither away, they come to the emergency room. We still provide that care for that client. The client is underinsured, has insurance, but that procedure is not covered by their insurance. Doesn't matter. We still provide that care within that setting that we're in to that client. The client is non-compliant. We still try to encourage that client, give them so that they can make an informed. We're not going to change their mind, but we want to give them enough information so they can make an informed decision, because we want to treat everyone fairly, and that is justice. So bioethics, of course, we're looking at all the different pieces, different disease processes, body systems, and then what's out there, what's the latest technology, health policy that goes to our politicians, all the people that are coming up with these laws and things. Do they have background and understanding of what hypertension is? Do they understand what diabetes is while they're creating these policies and things for us to abide by? Do they even know what it is? Is it realistic, though, some of those policies? So there are factors that commonly influence the development of ethical practice in nursing. So it can be your education, all this information that you learn, your family, your peers, and then from your workplace. All these things can influence what you do in your workplace while you're out practicing with nursing. Okay, let's look at this. I wasn't intending to show you all this one. I think I should. Did y'all see the answer? I want you all to read through and just put in the chat A, B, C, or D. We'll give you a minute to read through. Let me put my little timer on. 1 minute. Put it in the chat. What you think? A, B, C, or D? What should the nurse say? What's the best response? That's another keyword. What's the best? We can say all of these things, but which one is the best response? A, B, C, or D? 50 seconds. Let's see what we got. A, B, C, or D. We got everybody responded. We have mostly D. Okay, B's, and we got B's and D's. Yes, it does. Some common ones are, and that's even if people come back and ask, well, hey, initially, you say no, I don't have any questions, but that's why usually pharmacists, they go ahead and put those medication sheets in there, those health sheets, that information. Because once they get home, they're like, wait a minute, I'm putting something foreign in my body. What do I need to know? Is this or I'm experiencing my stomach hurt, my toe hurt, my head hurt? Is this related to this medicine I'm taking? So yes, we will let them know. Of course, we're not going to be telling them no, it doesn't have any side effects, because eating too many bananas or eating a banana, especially if it's not for you, it can cause side effects. So we definitely going to say that. And then we don't want to be passive in saying that we don't know. Maybe you ask your doctor, because side effects, we have the drug book, we have our drug cards. If you have the electronic health record, is there. And then you can, just list some of them. Oh, okay. This was another one I wanted you to put in chat, but I've already put it up there. Okay. So the nurse is witnessing potentially harmful behaviors in the workplace. A nurse should report any observed behaviors that are potentially harmful. We are mandated reporters. We do want to report that. Do you have to know all the details? No, you don't. They're going to work out, and you may actually be part of that committee facilities, healthcare facilities, for the most part, they have that ethics committee. So in addition to your regular job, an additional task could be you working on that ethics committee. And that's where if someone reports something, that investigation is done, details are gathered, it could be statements. They might even have to pull logs. So if in the event that a facility has a procedure, it may seem simple. For example, if we go to a facility, do you have to log in? The person have to write down that they're visiting? Do they have to get scanned through a machine and get a name badge? What is that procedure? It might not seem important, but if someone has a complaint, it says, hey, at 4 p.m., 10 people came into my room and took my mother's belongings. So they take that complaint. They have to work it up. You have to investigate it. And so with that, they would need to pull, who the visitors log. Who was at work? They even may have to roll back the footage from the camera just to verify. So you might be on the ethics committee. But in the event that we observe potentially harmful behaviors, we need to report that. So we talk about supporting our clients' autonomy. Beneficent paternalism, right here, it's really the opposite. You don't see this very often, but it's usually used for emergency situations. And it's usually where a patient or either the patient's spokesperson, whether or not it's a mom or dad or guardian, they've made a decision about the treatment options, the intervention. The healthcare provider, the PCP, thinks that they've made the incorrect choice. And they think, well, if you would just select this intervention, or if you would just go along with this treatment, then I know your child or whomever would be better. Beneficent paternalism does not guarantee that the courts will go with the doctor or the family members. It's just an opportunity for the intervention, the treatment options to be presented to a person that have no what am I trying to say? That has no benefit from whatever way they go. So beneficent paternalism is an attitude where the nurse or the healthcare provider assumes that they know what is best for the client, disregarding what the client actually decided they want to do. So this could be the nurse or the healthcare provider. And the information is taken before the courts. It's usually only used in emergency situations. All right, so ethics committees assist with difficult and ethical decisions in healthcare settings. I just said that. So when you are interviewed for whatever setting you decide to go to, see if they have an ethics committee and see, you might want to be a part of it. But usually those difficult things, those difficult issues and concerns, they'll go before the ethics committee. And they have a detailed process because you do want to treat people fair. So they'll go through their policies and procedures, what they normally, what should be happening. Is this the latest evidence base? They'll gauge all of that. And then you'll make a determination about whether or not it was relevant or not. So here we go. Critical thinking helps nurses sort out all ethical choices and legal responsibilities regarding this client care. This critical thinking is something serious. It is not only used for medical diagnosis. Critical thinking is not relevant for ethical decision making. It is relevant. Test taking tip. Pay attention to these little words. Like this NOT made this an incorrect statement. So when you are reading answer choices, make sure what you're reading is what's actually there. Critical thinking is relevant, but because it has is not, would not be a correct answer. Okay. Fidelity means being faithful to the client's best interest in maintaining that trust. We do want to establish those therapeutic relationships early on. So the client will feel safe to tell you whether or not, they don't want to do a treatment. Because a lot of times, the patient will say after the doctor has left out or the dietitian, whoever left out, you as the nurse go in, they're like, oh, I just signed that consent just because that doctor was looking at me. I don't really want to have this done. So this procedure done. So what do we do as that nurse? No, you're locked in because you signed it. You should have told them that you didn't want that. No, we don't do that. We'll bring that, doctor back in and say, hey, this client, they have more questions. They decided to not do the treatment option. It's okay. We're there to advocate for what that client actually wants. So nursing ethics includes these principles. And it's just like, well, hey, is this morally right or wrong? It's really what they all base down actually end up being. So the United States Department of Human Health Service, check our time, is a federal agency responsible for administering health programs and regulations. Let me stop sharing here. Let's do some what ifs. Let's do some what ifs here. Let's look at some what ifs. I don't know if one of our slides, but I'm just going to mention moral distress. I don't know if that's on one of the slides or not, but we're going to get back to the slides. But moral stress, MORAL, distress occurs when the nurse, when you as a nurse, know ethically what should be done, but you feel powerless. Because there's some situations that'll come up, and I can't think of one right up, but sometimes you'd be like, well, no, we shouldn't be doing this. And that's and you base it on what you know morally is correct or incorrect. And so that's called moral distress. It's when we know ethically the correct action that should be taken, but we feel powerless sometimes because it's like, hey, who am I? I'm just a little nurse in this whole facility. Not that the patient harm is coming to the patient or to the nurse, but there's some situations like, well, we can do this a little bit different. And then sometimes and that's why I say join some of those committees, and then so that you can be that voice. A lot of states have the day at the Capitol. Go and meet your politicians and, advocate for what you know and understand, or encourage them to gain more understanding about whatever the bill is that they're trying to actually pass. We had some students that how they have those town hall meetings, and so they had got together and they approached the congressperson to just go back and do a little research and maybe put out some other policies and procedures. Because, for example, if a person has hypertension, a person has some genetic disorder, some person has a long-term disorder that will require, for example, if that person is a child, it will require their mom or dad to take more days off work to take them to the doctor. But the way we have things set up, that mom or dad, we only get so many days, sick days, if you get sick days. It should be something in there to make it as even playing field. If this child is born with this, the parents should automatically, facilities and places of work should automatically have a different set of days. And then you revise that thing as evidence changes and as treatment option changes, because it's really not a level playing field. If a child is requiring numerous transfusions, and the child can't go to the doctor by themselves, they have to have a parent or guardian. And so they just advocated to just make it a little bit more even playing field by adding either extra sick days or whatever facilities call them, or just to have a whole nother set of days. Have this list. If you have this, then you get extra days to be able to take care of your child and provide care for your child. Okay. All right. So that example that I just gave about the patient changing their mind, what would we do? Would we just keep that information to ourselves? So you went in, the doctor just went in, just came out of the patient's room, or the dietitian. And the patient says, well, I just went along with what the dietitian was saying. I really don't like beef. I really don't like bananas. I just went along with what they said. And, I see bananas is going to be on the menu for the next 3 days. I guess I won't be eating my meal because I don't eat, whatever it is, tomato soup, or that I just signed off on it so that doctor can remove my toenail because that was a doctor looking at me. What would you do with that information? Would you just keep it to yourself, or would you notify that physician, that dietitian, about the wishes
Notify.
and what that client said? Go ahead.
Notify.
Exactly. You want to notify. Because remember, we're that patient advocate. We're that person that's speaking up for them. And believe they're gonna once you establish those therapy relationships, they're gonna feel safe with you. They're gonna tell you the good, the bad, and the ugly. And it's on you to know, hey, I know they just signed that paper, but this is what they just shared with me. And they know that it's no wrong. They'll come back and they may say, well, I didn't know, you should have said you didn't like bananas. We got all these meal options with bananas in them, and they'll laugh about it. And okay, well, this is what you can pick. And so, but yes, we want to notify that physician, dietitian, or whomever. All right. So we say autonomy. We do have to know these, y'all. Autonomy. It refers to respecting what that patient has decided. The patient can make an informed decision. We do want them to have enough information so they can make an informed decision. So we want to make sure things are in terms that they can understand. We may have to identify what their learning style is just to make sure, we may have to read it to them. We may have to have an interpreter. We may have to change the language to whatever if the patient's first language is German or whatever, Spanish. We want to make sure that they have enough information to make an informed decision. And we support that client's right to make that informed decision, to make those choices. Even if it does conflict with the provider's recommendations, we support that client's autonomy. Okay, so we went over beneficence, and it involves promoting the well-being for that client. Okay, is this treatment going to be beneficial for the client? Is this intervention going to be beneficial? Is it any beneficence, benefit? And then we said non-malfeasance, do no harm. The example that I gave was we saw that the dose of medication was a high dose. So, we did question that order. We just verified it, because we don't want to do any harm to this client. And then we said justice is fairness, equal access, just being equal to the clients, no matter what their pay source is, no matter underinsured. You can have insurance and still your insurance don't cover things, but we don't want to not take care of that client if they're there. Okay, so that was some what ifs for ethics. We went over the ethical principles. Let's see here. So we have our State Nurse Practice Act. So there's a national association that has the code of ethics. And so with that, you all know about confidentiality. We know we got to keep health information private. Even if you were taking care of this patient on med surg and they ended up going to ICU, once that patient is no longer in your care, we shouldn't be looking at that client's record. We want to keep that. We want to protect the patient's privacy. We want to maintain confidentiality. We don't want to violate HIPAA. Okay. All right. Let's go back to our PowerPoint here. Okay, so let's talk about medical malpractice. So what are those components? I'm trying to share my screen, y'all, that equals malpractice. What are those components that equal malpractice?
Like doing something wrong.
Anything that causes harm.
Like neglect.
Like,
So
abuse.
what is that tool that says, hey, they malpractice? What's that tool or that gauge that they're going to use to determine whether or not we did what we were supposed to do for this client or we did not do what we were supposed to do for this client?
The HIP.
A tool?
What's that
Is it like a law, a state law or something you're trying to say?
Think about what we use to take care of the client.
Oh, care plan?
Care plan. That care plan is the recipe, it's the to-do list to take care of that patient in room 201. Remember, it tells you, I know like for clinicals, you all may do like 1 or 2 care plans, but realistically, if a person's in a facility, they have a care plan, they have a whole bunch of care plans. They have a care plan addresses all of their issues. So that's the recipe, that's the tool, that's the guide that says, hey, this is what you need to do to take care of this patient. And so what they do is for malpractice, this is it right here. For malpractice, they say, well, hey, well, what if the care plan say? Well, so this is a scenario. The patient in room 201 requires 2 persons assistance for turn and repositioning. That same patient requires 2 people for showering. That person may require 1 person assisting while walking in the hallway. So while the person's walking in the hallway or even in the shower, they end up falling or having some type of injury. Meanwhile, before the person fell or end up with a type of injury, there was a nurse or there was a unlicensed personnel with that person. That person got a phone call and they stepped away. They just stepped out of the shower. Is that part? The care plan said 1 person assists with the shower, 1 person assists while walking in the corridor. If the person, the nurse or the UAP stepped away to take that phone call, is it 1 person assisting this client anymore?
No.
So when that client failed, they're going to say, well, wait a minute. What was the duty of that person? Was it the UAP or the nurse's duty to provide that 1 person's assistance? Okay. Yes, it was, because I was assigned to this patient. This patient was on my team. The nurse walked away. The client had an injury. So then they say causation. Is there any connection with the nurse or the UAP walking away in this client's injury that they sustained? Would this client have sustained this injury if that 1 person would have still been there with this patient? And if they can meet all of these components, then they say that we have malpractice. Even with the abuse, we got all the different forms of abuse. What's that one that we don't really think of it as? I think we have a slide on it. Involuntary seclusion. No, we go back. Involuntary seclusion. The patient room 201, they keep disturbing everybody. So we close the door up. And meanwhile, their care plan says to assess the patient or check on the patient every hour. We've closed the door up and we haven't been back in there because we don't hear them. And so, we just so glad they're not making up noise and disturbing the others. And when we do decide, the nurse do decide to go in the room, the UAP does decide to go in the room, the client is, have fallen. They've fallen or they could be unresponsive or something has happened to them. Where the care plan said, hey, in the event that this client was displaying hollering out, the care plan says, change environment. A lot of times they'll say to, involve them in some type of activity, assess for pain. And in the event that that client failed, sustain some type of injury, and it could even be death, is why, they look back at the logs, they roll the cameras back, and they realize, or some staff say, hey, we always close the door because we be tired of that person hollering out, disturbing the others. And they realize that this patient was assigned, and we did not go in and assess this patient. In addition to that, we didn't assess their pain. We did not give them a different activity to do, because a lot of times they will, if they don't appear to be in pain, appear is not a good word. If they're not in pain, they'll give them like all these little different activities to do, like we've seen, like little vests. They'll give them a basket of stuff to fold, something to distract them. And if they don't see where all these, that we breached our duty, that we didn't implement those interventions that's listed on that care plan, and there was an injury, they say, well, hey, had we assessed for pain, had we given them their activity vest or whatever the alternate activity was, would they have had this injury? So that's what that malpractice, that's what they look at. So it is improper for a facility to get referrals or monies or any type of incentive for referrals or anything like that. So Dr. Banana always sends his patients to Dr. Apple at the Orange Hospital. Well, that might be like the closest, and he might have privileges in that hospital. But they find out that Dr. Banana is actually getting money kickbacks or some type of incentive. They may get a red truck every two years. They may get free groceries or some type of incentive for sending those patients to that facility or to that being referred to that specialist. That's against the law. Now they just outright they don't have privileges anywhere because they have to have privileges in all these hospitals. They can't just go to the hospital and start working. So they're not on that staff, then that person can't go there and actually work. But they can refer, because especially if a client says, well, hey, my closest hospital is hospital A, and you send them to hospital B for no reason. If they have availability at hospital A, that's the closest, that's that client's preferences. Why are we sending them to hospital B? Well, because Dr. Banana is getting all these incentives. Well, that's illegal. Can't do that. Okay. We talked about HIPAA, protecting the client's privacy. So advanced directives allows patients to specify their healthcare preferences and appoints agents for decision making. So these are legal documents. It tells us the wishes of the patient. Now, we can feel how we want to feel about it, but if a client has these documents, living wills, advanced directives, and for example, if it says that they are DNR, do not intubate, all those different orders, and we just feel, if we just do that 2 chest compressions, we can bring them back. In the event that they have that legal document, that DNR, or if it's written in the advanced directive and we perform that CPR, then we have violated that client's rights. We have taken away their autonomy. Okay. So like we say, just be careful, making sure that you're practicing within your scope. It's unfortunate, but people will ask you to do things that they know that you're not supposed to be doing. So it's going to be on you. You're not going to be protected by that mentor, that your preceptor, or your clinical rotation instructor. So it's going to be on you to make sure you get in there and get that State Practice Act. Look at those videos and webinars. All states have like these things that they want you to know, and they'll send you videos and webinars. You'll have your own little login. You can look at that information, and you will need to take the time to look at it, because like I said, unfortunately, people will ask you to do things they know you're not supposed to be doing, but it's going to be on you to say no. No, nope, nope. I'm not licensed to do that. Have you in there suturing and all kinds of things. Yeah, you can do it. You see me do it. Go on in. So a tort law provides relief to harmed parties, imposes liability, and deters wrongful acts in healthcare. So torts can be intentional or even non-intentional. There's still, guidance on, what should happen to that person, even if the nurse did not intend to harm that client, but they might not have followed the medication administration rights. They didn't verify that this was the correct client when they look back at the situation. And so another example is questioning those orders. Did you not notice that this was a lot of medication, a large dose? Yeah, I did recognize it. I just administered because the pharmacy, they packaged it. It falls back on that nurse. We didn't intentionally harm them, but they still hold us accountable. Malpractice is professional negligence resulting in harm to the client. Talked about those 4 pieces. Oh, and so another thing, when you are sometimes they'll change up your assignment. You as that leader or team lead or whatever, and if you're that nurse, that team nurse, just make sure that the assignments, if you get a change throughout shift, make sure it changes, that change is reflected on everything, because you don't want it to be something happen with that patient, malpractice comes the question about, well, has malpractice occurred? They're going to look at who was assigned, who had a duty to this patient. So if assignments changes, I needed to reflect on everything, because it needs to show who I'm responsible, who I have that duty to take care of, and who I'm not have a duty to take care of. Because you don't want to get caught up in that. Well, I thought it was your patient. I thought it was your patient. Okay. So they do change up. People get discharged, they get transferred, people pass away, they go home. And so they try to keep the assignments as equal as they can. So therefore, during the shift, sometimes you may start off with 8 people, then you may end up with 10 or 6 or however. But just make sure on whatever is being changed that it does transfer, because we don't want it looking like you as a nurse were supposed to be taking care of that client or had that duty when you really were not. So informed consent requires a client understands the procedure, the risks, the benefits, and look at this right here, alternatives. You know, the client says, hey, I signed off on that consent, but I really want to know if there's something else I can do for this, for this ailment. Is there something else? Is there some medicine I can take? Or is it a different type procedure? If they actually say that they want to know about an alternative, we got to get that health, we got to notify the healthcare provider. Say, hey, I understand they signed off on that consent, but they're telling me, they want to see what are their options. And that's okay. And that healthcare provider shouldn't have a problem with coming back explaining what are the alternatives. So they know this. So for the most part, they do it from that initial conversation with the patients. But they got to tell them the risk. Hey, doing this procedure is risky. I've done this procedure however many times. They usually give them their percentages and say, well, hey, I've done this procedure 20 times, 18 times. People had success. They went on to, whatever the benefits were. That I had those 2 people. I'm not saying this is going to happen to you, but you got to let them make an informed decision. So the living will, we talked about that. That's a legal document. It specifies the desired medical treatments if the person is terminally ill and they can't make decisions for themselves. They write it out. I think most facilities now, I think each time you go into the hospital now, they ask you, do you have one? Do you wish to execute one? And I think maybe even in the long-term care facilities, they've trended for that too. So that social service person or that case manager, in the event that they said they want one of those documents, they'll go ahead and get the lawyers or whomever to go on and get that done. So a living will and a power of attorney are duplicate documents. They are different. One specifies the person, and the other one just have it all out in writing. No one has to make a determination. It's written. I don't want whatever it is that they don't want, and that's a legal document. And people list all different kinds of things on those legal documents. I would say you don't see legal documents a lot, but you do see them. And it's no guess. They have it outlined if they decide on a person to make those decisions, or if they decided themselves and they spell it out. Number one, anything that you find me without heartbeat, respirations, do not do chest compression, do not do CPR. They're specific. I don't want IV fluid. They're specific. So the Good Samaritan Act, it does provide immunity. You riding down the road and someone's had an accident or something's going on and you stop to render aid. You do that in good faith. And so this Good Samaritan Act provides immunity so that person or whatever, those people can't come back in and sue you because they said, well, whatever, you made it worse. Well, this Good Samaritan Act provides the nurse or the healthcare provider immunity, and at the least you can call 911. But if you actually stop and render aid, then you're just doing that in good faith. And you'll be surprised on, with the cars and the conditions of roads now. If it's storming, raining, you just never know what you'll end up running up on and what you'll have to do. But you decide to stop or not stop. But if you do, that Good Samaritan Act is there to assist you, to protect you, provide immunity. Okay, how is false imprisonment defined in the context of the nursing law? False imprisonment occurs when a client is detained against their will without justification. False imprisonment occurs when a client is detained against their will without justification. Think back at the scenario that I gave you. The patient in room 201 was making all this noise, disturbing others. We closed the door. So that client is really being detained, You can, and so we just want to make sure that we're following those care plans, and because they do have interventions on there that addresses that. Because if we've been assessing that client and reporting that they're hollering out, then they should have a care plan that addresses behaviors and what to do. It's not a mystery as what to do to take care of this client. That care plan, remember, is specific to that patient. Okay, let's do some more of this real quick because our next hour, we're almost down to our next hour to take a break here. We said that the code of ethics, it requires us to maintain confidentiality. That means keeping people's information private. Okay, let's see here. So the big chunks for for this first exam, of course, was clinical judgment. We've been talking about critical thinking, clinical judgment, which is, part critical thinking is part of it. Ethics is a huge one, and then that healthcare law, those legal documents. So professional and personal values. So hopefully you all have been listing your top 4, places that you might want to work. And hopefully you've been pretty much, looking and seeing what they do in those facilities. Because remember, you have that Nurse State Practice Act. Those are those things that you can legally do. But personally, you might not want to be doing whatever those procedures are, be involved. But professional values, they guide the nursing care that we actually provide, even if it conflicts or bumps heads with our personal beliefs. Like in this facility, they might remove toenails all day. We might not want to be removing toenails because personally, we just might not want to do that. But professionally, lawfully, legally, we can assist. We can set up that whatever that field. We can, we can provide that wound dressing change. Professionally, we can. But then personally, that might not be a procedure that we have a conflict with. So, make sure that when you're doing those interviews, look at that responsibility list, that task list. They call them different things, your job duties, your job tasks for that facility, because they're going to have pretty much everything that they can provide, those facilities, all the different procedures and things that they can provide. They're going to have it on there. But personally, there might be some conflict. But those professional that our Nurses State Practice Act, it guides the nursing care that we can give. But personally, that nurse might not want to provide that care. So that might not be the facility for you, and or you want to go ahead and have that conversation. Well, if I'm assigned to toenails on day Monday, can I not choose an alternate assignment that day? So just start early on to asking those questions. Individual have rights, but individuals' rights cannot infringe upon someone else's rights. So, a person has the right to make a choice, to choose between alternative treatments. They should have a right to ask about those alternative treatments. They have a right to consent to care. They have a right to change their mind. They have a right to refuse care. That patient has the right to decide what they want for them by their own bodies. But when it comes to what they want, if it's going to cause harm to the healthcare provider and the patient that's in the room with them, then that's not, we're not supporting that. We don't want harm to come to the others and ourselves. So, but they do have the right to consent, to change their minds, to refuse, a right to receive enough information so they can make an informed decision. And they have the right to know if there's an alternative. What is, they can refuse even, I don't know if you all have rotated and a client has actually left against medical advice, really wasn't in their best interest, but that client refuses to stay and they want to sign out. That client has a right to refuse that treatment, even if it means that treatment, what they have going on right then, will save their life or extend their life or make their life, of better quality. They still have a right to refuse. That's like the example that I gave with a patient, has it written. They have a legal document that says do not resuscitate. And we like, oh, we could just do 5 chest compressions. No, they've already decided. They've already decided. Okay, let's see. One more what if, and then we'll go to our second break. Let's see. Doo-doo-doo-doo. So again, you see why I'm saying you have to not just know what the concept is, you got to be able to apply it to a situation. Because these next gen questions, you got to know what the definition is and pick it out and go through the scenario, see if there are any connections. So you do need to know that cultural competence involves actively learning about your client. That comes from that therapeutic relationship. When we go in and assess them, we're going to, be asking those questions, so that we can learn about, what are their goals for their care? What's their understanding? What are their values? And then from that, we create this individualized care plan. That's part of being culturally competent. We're not just automatically going in thinking this is it for, this patient. All right, so we are at the bottom of our second hour. Let's stop and take our 5-minute break. When we come back, we'll go ahead and get in our week 10 project groups, and we'll let you all greet each other and do some decide, what your actual next steps would be. Now for your group project, you have to meet the size during class time. Now that Zoom over the phone or however you all decide, but you can't rely on getting that project completed during class time. So let's see, what time is it now? Let's see. So let's meet back at 7:36. 7:36. See you in 5.
Hey, are you gonna take questions at the end? Okay.
Yes.
All right. Thank you, Dr. Ford.
All right, you're welcome. Just give me a few minutes. I'm gonna place you in your breakout rooms, and this is for your week 10, the project. I know we mix up, we do small groups, just sharing out and all that. But this is your week 10, and plus I'm gonna place it in the announcement section, and also
Will
If you
we
want to
be
put
able to
me and
pick
my
who we
person
want to
on the
be
breakout
partners with?
set, I would be fine with that.
I have it right here.
You at least be in the same city.
So that's
No,
right
No,
we'll
because I
there.
have
So
think
you'll
to.
only
see in
one
just a
person on here
moment,
can
you all.
name.
You'll see in just a moment. Hold on. Miss, okay. Everyone has their name, right, according to the roster, right? Let's see. Okay. Let's go back up here. Get that one. Okay. And remember, it is a PowerPoint. They did not make the change. So once you get into your group, I'm going back and checking, making sure I got it clicked right correctly. I thought we had everybody here tonight, but anyways, so it still says, what does it say on that rubric? Does it say a poster? I think it says a poster, but it should be a PowerPoint. And so they didn't update there's not a slide count, but you do want to make sure that you have covered each of those bullet points in on the rubric. Some of y'all have disappeared off the screen. So I'm going to open up the breakout rooms, and I'm going to post this. Hold on, let me post this first, and then I'll open up the breakout rooms. There are 3 of you I can't see on the screen for some reason, like your name has disappeared. But once I open up the room, I'll assign you to the correct room. I'm not sure what that's all about. It's probably maybe just a user issue. It might just be me. But I can't see 3 of y'all's name for some reason. But anyways, we'll assign you once we get you in. And this is your week 10 group. Don't get mixed up with how we how we met earlier. This is your week 10 project. And I'm gonna post it in, open up the breakout room. Let you all go on in. And just start introducing yourselves and everything. And then open up the announcement to see. The room is open, accept the invitation, go on in, see what your topic is. Just start talking about how you're going to communicate. If you need to communicate fast, is that Zoom? Is that a text? That's WhatsApp, whatever you all decide. I'm not sure what this computer's doing. Okay. So accept the invitation. There are about 3 of you all that your names disappear. So hold on, I have to assign about 3 of you all. Because for some reason, I couldn't see your names went away. So I will put you on in. Okay, I'm submitting the groups and publish. All right, so let's see who I still have right here. Miss Green and Michaela. Okay. Let's see. I think I just got too many tabs open, y'all. I think I think it's the user. Okay. So you all should be Evans, Lydia, Ashbury. Where y'all at right here? Okay, so I'm gonna move y'all to that's group 9. Okay, there you are. Okay, I see y'all names now. Okay. So y'all go to room 9. Room 9. Got it. go. Okay, so while you all are doing that, I'll cover the rest of our content. Share my screen. So be sure to go back through your classroom recording. Look at your required readings. Be sure that you have enough time to complete that quiz, because remember, it's in one sitting, those 50 questions. All right, so a DNR, or do not resuscitate order, is a legal directive to withhold CPR or advanced life support. So no matter how we feel about that client's status, in the event that we find them without, heart rate, respirations, blood pressure, and if they have that DNR order, that is legal. We have to abide by that. We do not perform that CPR. So, what is the nurse's legal responsibility regarding suspected client abuse? Do we have to know all of the details? If we suspect, remember, we are mandated reporters. And so nurses must report suspected abuse according to the facility's policy and the state law. We got to report it. Now it's on someone else. They'll come in and do the investigation and gather all the data. Personal liability means a nurse is responsible for their own actions and decisions. So it's going to be important for you to know what your state nurse practice act is and what it says. But like I said, usually your facility's policies and procedures align with that. The problem is sometimes your coworkers might ask you to complete some tasks and things that's out of your scope, but it's going to be on you, because remember, personal liability, the nurse is responsible for their own actions. Like right now, you're up under your clinical instructor, their license, but once you get those licenses, you're responsible. So it is a criminal offense if a person takes or steals and use the patient's medications, their debit cards for their own personal use. That is a criminal offense. Even if it's their medications and they are enrolled into a facility. They're actually, admitted they stay at that facility. We should not be using their medications, their personal belongings. That is a criminal offense. That is a criminal. We talked about medical malpractice. It is a type of civil law, a civil law violation, and occurs when the nurse failed to meet the accepted standards of care, resulting in harm to that patient. Remember, we looked at that slide. Was this patient assigned? Does that nurse have a duty to that patient? If they were assigned, they have a duty. What did that care plan say in order to take care of that client? Well, it says this person blood pressure should have been checked every 4 hours. The documentation indicates that this person's blood pressure was not checked at all during the shift. That person had a stroke. That person has some residual. They can't use, the right arm or leg, or they're having problems with speech. So the harm came to that patient. Was it a direct cause related to the actions that nurse did not take? That's malpractice, and it is a type of civil law violation that occurs when the nurse failed to meet the accepted standards of care, resulting in harm to that client. The example that I gave earlier about the client needing one person's assistance when they're walking in the corridor. The nurse stepped away to take a phone call. This client's walking by themselves. They actually fall down and they injure themselves. It might be some scrapes. It might be a broken hip. But did that nurse's lack of actions, the care plan say specifically our interventions, what we should be doing? And if there's a correlation, if there's a direct cause because we stepped away, they can make that. Then we have malpractice. We have caused harm to that client. In the event that we go in and do a procedure, if a healthcare provider, the doctor does a procedure to a client without their consent, that is illegal. That's considered battery. We can't go in and do a Foley catheter. We can't put in a Foley catheter. We get permission to do dressing changes. I'm here to give you medications. Is it okay that you take your meds? Are you going to take your meds? We can't just automatically say, hey, you can't leave this facility. You can't leave AMA. While it might be against that patient's best interest, we can't keep them there. That's imprisonment. We can't keep them there in that hospital. We cannot, in the event that we perform a procedure, without permission, without consent, that is battery. If a patient wants to leave against medical advice and we can't keep them in there, that's imprisonment. That client we're going to support them. That client has a right to choose. They just have a right to choose. It might, like I said, it might not be in their best interest, but that client has a right to choose. So let's go back over. We talked about malpractice, a legal wrong involving harm caused by the nurse's failure to follow what those standards were. That's malpractice. Okay, so then negligence. We have negligence, and then we have torts. So a tort is a civil wrongdoing that causes harm, leading to that legal liability. So it's caused that client harm. We didn't do our medication administration rights. Whether or not it was intentional or unintentional, we caused that client harm. So defamation, making statements or saying things that will damage or negatively affect someone's career, that's defamation. So we want to be careful with sharing things like on the different social media sites and things, and we're sharing things, and it defames or negatively affects someone's character. We're talking about beyond the hospital setting. Defamation is a thing. And so, you want to be careful sharing, because it's like you're sharing that information that defames or negatively affects that patient or someone altogether. So you just want to be careful with sharing information on the social media sites. Okay, we did say that we were mandated reporters. If we suspect abuse, we don't have to have all the details, but if we suspect, we must report that. Okay. Nurses have a legal responsibility to report any professional whom they suspect that's engaging in something that's illegal, immoral, or unethical. Failure to report is a violation of the code of ethics. They contact and report to the State Board of Nursing. We're mandated reporters. We don't have to know all the details, but we're mandated reporters. We are actually reporting that we suspect. Okay. When reporting incidents, subjects to good faith immunity, the nurse or the healthcare provider may be required to disclose private health information. Disclosure of this information under these circumstances is not considered a violation of HIPAA. But if we're just haphazardly, because we're talking about a suspected abuse, then protected health information might have to be released. But if we're just having just a roundabout conversation, we should not be releasing private information to anyone. So sentinel events, these are events, is an unexpected event that will result in the potential serious patient harm or death. These events, they don't occur often, but it does in the event that something like, for example, they go in, this client went in for a routine hip replacement, and this client, end up dying, doing surgery. That's a sentinel event. A sentinel event is an unexpected. We got an unexpected result. This client died. It was not expected that this client would die from having, a hip replaced. So it's where serious harm or death occurs. And this does trigger an institutional investigation. They're going to look into that. JACO, all those people, they come in and they investigate just to make sure. I mean, that patient might have just, it may have been just their time, but they want to come in to look at everything, make sure policies and procedures were followed. That's why it's important to make sure that you're documenting everything, that you're taking the time to document. The Joint Commission requires that root cause analysis after a sentinel event to identify, to look at and see, well, hey, is this the system, the policy and procedure that this facility have in place? Was it a good policy and procedure, or did the system fail? Because if it failed, they don't want this to happen to anyone else. It should not be expected if a person comes in to have surgery, that they automatically leave their, picked up by a hearse. No, that's not reasonable. So the Joint Commissions, they come in, they require that, what we say, that root cause analysis. They look at everything and try to identify, to see if the policy procedures that are in place, are they good, or do we need to go back and look at things. So that sentinel event, it is unexpected occurrence. That is serious physical, psychological injury, or even, and it also involves death. Like I say, it does trigger that root cause analysis. Just look at everything and make sure that that facility is doing everything that they're supposed to, that they should have done, that they actually should have done. So if in the event that we are, know that you have a supervisor or a nurse manager there. As new nurses, you may see some things, and, you're unsure of, like, while your team, your teammate is doing, you thought that they're supposed to be going in, documenting, checking vital signs or whatever, but they are documenting things that are not really happening. So we're expected ethically we're supposed to report that behavior. So that's why that's why you have those nurse managers, and those, depends on what facilities you're in. They call them supervisors, directors of nurses, but know that we have to report that information. We do have to report that information. And like we've been saying all night, make sure that you're working within your scope of practice. Make sure when you're reading the questions, if it's asking you what should the LPN, the unlicensed personnel, or is it asking you about the registered nurse? So make sure we are practicing within our scope of practice. Remember, we said assess, analyze, interpret. ABCs, airway, breathing, and oxygen. Those that guides our priority. And then from there, we look at Maslow's hierarchy needs. We look at that bottom layer, food, water, shelter, and then we go from there. As always, you will have math on your exam. So take a look at the math resources that's been provided in the announcement section. Make sure you take a look at those. I will provide the exam links, the exam review links. So make sure you look at that. Make sure you have both of your devices, your chargers. You will need your ID. So make sure you have that. All right, everyone should be back. Hopefully you broken the ice and talked to each other. You have, your plans might change, next week or however you decide to divide things up. And so look at your rubric and I know those titles that we gave you, they're huge titles, but you're gonna piece it out. You're gonna have, there's not a slide count, but there is a time. I think it's 5 to 6 minutes, whatever your rubric says, but usually you all do well with the time because once you take all the moving parts of that big title, you have more than enough information. And so you can decide, how many slides you want each person to do. If you just however you all as that group decide. You should have decided on how to communicate. You might need more than one way, especially if it's something like urgent where I need to say something to my teammates really quick. How are we going to communicate? But for sure, you cannot rely on just your class time to complete that. And now it's in the future. It's week 10. So don't not work on it either. So just be doing little bits and pieces of it at a time. The last 15 minutes, we're at break, so you're free to log off. For those that you have questions, I'll go ahead and answer those. But otherwise, we'll see you next week. Exam 1 and week 3.
Good night.
Miss Ward, where is the rubric?
It's under week 10. It's week. It's
Oh,
week
week 10. Okay, okay.
It's week 10. It's far off, y'all, but don't let it sneak up on you because as time goes along, you're gonna have your other classes and work, play, school, all these things. So don't procrastinate.
Okay. Thank you.
You're welcome.
Hi, Miss Ford.
Hey.
I got a question. Is there any possible way that I can be switched to another group?
No, that's just how it is, the way we assigned it. For the most part, people are in the group with someone that is on their campus. And so, therefore,
But not everybody communicate. Not everybody communicate with each other. And
yeah. So send me an email, Miss Bill, with the details. Include Dr. Tenza in the email.
All right.
Okay.
All right. So my question is basically the delegation